everybody. Bienvenue tout le monde. Welcome to this year's Hirsh Rosenfeld Public Lecture, which is a collaboration between the Department of Family Medicine and the St. James Literary Society. For those of you who may not know, I just want to tell you a little bit about the Department of Family Medicine. I'm Dr. Marion Dove. I'm chair of the department, and it gives me great pleasure to let you know about the department and also to welcome one of my newest colleagues, Dr. Justin Sanders. We have, Justin, a lot of people here en personne, and for those of you who are here, we have some food and wine for you, and we have over 50 people online listening to you, including people who are in Justin's family. So I believe Justin's parents are here with us virtually, which is very nice. So a particular welcome to them. So the Department of Family Medicine, well, we're a global leader, just saying. In family medicine, we work on creating healthier communities through inclusive and innovative world-class education, care, and research. We have primary healthcare professionals, researchers, students, and support staff who are all dedicated to delivering effective patient-centered care and advocating for our patients, for vulnerable populations and communities. And I'm really proud to be chair of this department. One of the more pleasant tasks that I had as chair of this department was working on recruiting the Flanders chair in palliative medicine, who is Dr. Justin Sanders. So Dr. Sanders joined our department in 2021 as the Kappy and Eric Flanders chair in palliative medicine. He has a BA in art history from Haverford College and an MD from the University of Vermont, which, as we know, is just a little bit south of here, but he wanted to come even further north. He also has an MSc in medical anthropology, which he completed at the University College London as a US-UK Fulbright postgraduate scholar. He completed residency in family medicine, and he was chief resident at the Montefiore Medical Center in the Bronx, and he completed a fellowship in the Harvard Interdisciplinary Palliative Care program at the Massachusetts General Hospital and the Dana-Farber Cancer Institute. He was a research fellow in cancer communications outcomes research, and then the associate director of innovation in the serious illness care program at Ariadne Labs, a joint health systems innovation center at the Brigham and Women's Hospital and the Harvard T.H. Chan School of Public Health. So the interesting thing about Justin is that he's a doctor, but he really focuses on communication, and his interests lie at the intersection of culture, communication, and serious illness. He focuses on promoting authentic healing relationships. He works in both qualitative and mixed methods research, and he is one of 3 principal investigators, or he was at Ariadne Labs in the Virtual Communications Research Lab, in which he uses virtual technologies to study emotional and cognitive impacts of verbal, nonverbal, and environmental aspects of communication. So I'm thrilled that he's here tonight to talk to us, and he has chosen as a title, Relationships in Serious Illness and How to Build Them, because he firmly believes that palliative care is not end-of-life care, as we all like to think, but it really starts with serious illness, and that relationships are a key part of healing in all serious illness. So before we turn it over to Dr. Sanders, we are going to hear from Mr. Samuel Brauman, who is head of the St. James Literary Society. And Mr. Brauman is joining us virtually. So I'm going to see now how we work this technology to turn it over to Mr. Brauman. Mr. Brauman? He's got to unmute himself. Maybe he doesn't appear to be online. All right. Well, if Mr. Brauman comes online, we will hear from Mr. Brauman at a later point this evening. And I just want to maybe remind all of the participants who are online just to keep yourselves muted during the presentation. And we will hear from Dr. Sanders for about half an hour. And then we will have a period of questions and answers. So if you in the audience have questions, please feel free to hang on to them until the end of the presentation. And those who are here, you'll be able to speak your questions. And those of you online, feel free also to put any questions into the chat, as we will be monitoring the chat. So with that, Dr. Sanders, it's my pleasure to turn the microphone over to you.
Well, I'm very honored to be here and to give the Hirsh Rosenfeld lecture. I'm so grateful to all of you who came in person. It feels like we're moving back towards some new reality that is kind of like the old reality. And I'm grateful to the Department of Family Medicine and to you, Marion, and to the St. James Literary Society for their sponsorship of this event. I think it's interesting that you said that I am both a doctor, but interested in communication. And so I think we'll talk a little bit about that tonight and the implications of that assumption or that assertion. So tonight I want to talk about relationships, which I believe are fundamental in healthcare generally, but of heightened importance specifically to people affected by serious illness. And we're going to talk about how to build them. Now, you may find it funny to think about relationships somehow being built. We tend to think of relationships in the same way that we think about breathing, which is to say not much at all. While we may not take the people with whom we are in relationships for granted, we often take the circumstances of their formation and their persistence for granted. Now, it's not entirely uncommon to say that we might build a relationship with someone, and this implies an intentionality that I would really like to lean into tonight. I'm getting some tech support. What I want to imagine together in thinking about building relationships in serious illness is really about how we redesign or at least reorient a healthcare system to value something of extraordinary and indeed timeless importance between a clinician and a person in need, and between that person and the world and the people around them. I will propose that relationships are in fact a key to addressing some of the major challenges in healthcare, and that they therefore in fact deserve our rapt attention. So how do I move?
Yeah, now touch that. Yeah.
So I should start with some disclosures. So I have no financial conflicts of interest or disclosures. I will, however, name that I am a white, cisgendered, able-bodied, and heterosexual middle-class married physician and scientist. And so it may go without saying that these identities confer some advantages in society, but just as important, and the reason I have begun to name this social position in a lot of the talks that I give is that they collectively inform my perspective in ways that are both overt and covert. And I hope that doing so signals an openness to conversation and perspectives that may differ from my own based on people's other experiences in life. So. Okay. So if we're going to talk about relationships in serious illness and how to build them, we should first think about why that matters. Let's see, I'm gonna...
Mary, are you there?
Yes, but it's hard to hear.
And online at the same time.
There you go.
Okay, thank you. So let's see. So what am I talking about when I say serious illness? Okay, so an international group of palliative care physicians and others in related fields got together and came up with a consensus definition of what serious illness is. And what they say is a serious illness is a health condition that carries a high risk of mortality and either negatively impacts a person's daily functioning or quality of life, or excessively strains his or her or their caregivers. You know, in an attempt to try to be objective, there's still some subjectivities in here that we could talk about. But I think what is maybe more helpful is to think that these would most commonly be thought of to include advanced or metastatic cancer, end-stage diseases of the lung, heart, kidney, or liver, neurologic diseases like ALS, and to some degree and at some stage dementia. Now, while some people still think that palliative care is only for people at the end of life, as Marian said, it is important to convey that the medical literature demonstrates a host of benefits for people receiving palliative care across the trajectory of serious illness. And I will come back to that in a little bit. So there are some unique features of the experience of people affected by serious illness that are worth mentioning. First, people affected by serious illness experience physical discomforts due to their diseases or to the treatments that they receive. In addition, this means that they may take medicines that hopefully make them feel better, but also leave them feeling less like themselves in small or big ways. Second, they face complex decision-making related to treatment and how to spend their time. These decisions are almost universally characterized by trade-offs, which means that there's always consequences, almost always negative consequences to any decision that you make, even if there are positive consequences as well. Third, and this may be an extension of the notion of trade-off, is that these treatment decisions often involve a risk of hastened mortality or prolonged dying. And finally, and this is almost certainly a consequence of the other features, but also due to the fact that serious illness conveys a high risk of dying, patients and families experience heightened anxiety. So in this setting, I'd like to provide two rationales for the importance of relationships in this context. The first relates to what people who have a serious illness tell us about what's important to them. And the second relates to what we've learned from palliative care about how to respond to their needs. So it can be helpful to look at the literature that tells us about people's values in the setting of serious illness. That is what matters most to them. Now, hospitals, including the one that I work in, often try to fit an oversimplified heuristic to patient values, such that patients either want to live as long as possible at the expense of comfort, or that they wish to focus on comfort at the potential expense of longevity. But as a moment of personal reflection and maybe even common sense would tell us, the reality of what people value in general and in serious illness is much more complicated. Some of the most compelling work on this comes from Canada, my new country. Darren Hayland and colleagues asked patients and caregivers to rate a set of predetermined value statements in order to get a sense of their relative importance. And this is data from some of their work. And this is a table that shows the median importance to these groups of these various values and beliefs. And these boxes highlight those values that were of higher importance. Now, for the most part, these align with what we might think of as a comfort-oriented approach to care, to be as comfortable and to suffer as little as possible, to avoid being attached to machines and tubes, that nature be allowed to take its course. And at the same time, having more time with family was of highest importance, and living as long as possible was not far behind in ratings of importance. So from one perspective, this complicates the narratives that patients either want one thing or another. And from another perspective, it's perfectly reasonable to want both of these things. We both want to live as long as possible and as comfortably as possible. Now, these researchers found that there was a disconnected time between people's stated values and their decisions regarding orders about resuscitation. That is, whether they would want to have CPR and or mechanical ventilation. And I would hypothesize that having more time with families somehow relates to this evident discrepancy, all of which to say that relationships are of the utmost importance to patients and families. And it feels almost ridiculous to say that because it's so obvious. I want to share findings from two more studies, the next of which is research that I led, to examine values among patients with advanced cancer in a trial of a serious illness communication intervention at Dana-Farber Cancer Institute in Boston. Now, the paper in which this data was presented was actually about goal concordant care as measured by the degree to which preferences were rated as being achieved. But there's a story within a story about what matters most to people. Among a set of predetermined values, patients rated being at home, being physically comfortable, and being mentally aware as the most consistently important to them, with living as long as possible the lowest rated among all surveys, but still among the top 3 goals for about a quarter of respondents. But more telling than their ratings of values or goals as they were given to them is what patients themselves listed as their goals, listed as their own goals. And I apologize for the size of this text, but what you can see, fortunately the screens are large, but what you can see here is that over 80% of people articulated goals that had something to do with relationships. Want to see my granddaughter born, be a good and supportive father, healing family wounds. And of those that described surviving to events as important, most of these were also about relationships. Seeing my children get married, having a 50th anniversary, or attending a niece's high school graduation. I think all of this survey and qualitative research points to something that's rather obvious, which is that we make sense and meaning in our lives in relation to the people around us. And when we catch a view of the horizon in front of us, these relationships become the most important thing. Now, much of my own research has been and is about how we improve care by improving communication and relationships between clinicians and patients, because evidence in my own experience suggests that these relationships are also important. Sally Thorne is a researcher in British Columbia who published an absolutely beautiful paper in the early 2000s about the experience of human connection in cancer care. Interviews with over 200 people in active or prior treatment for cancer revealed the importance of what she called being known. And I pulled some of the quotes from this work to highlight the positive connections described by patients. So for example, one said, the surgeon was focused on his specialty, but my doctor here is focused on me. And he knows me well, and he knows the whole of me. Another talked about the relationship with their physician as comforting. Somebody just saying to you, I care who you are, and I know who you are. I know where you have come from, and I believe that we should be doing these things for you. And finally, another speaking of his or her physicians noted their compassion. She made me feel that my welfare mattered most to her in the world at that moment. I thought I was loved. Now, I find this to be a really beautiful description of how it feels to be truly cared for. So having highlighted data that speaks to the importance of relationships, I'd like to speak a little about palliative care suggests about the importance of relationships. People may have heard me say in the past that I believe there are 2 radical ideas at the core of palliative care philosophy and practice. The first relates to the nature of suffering, and the second relates to the possibility of healing. In her writing on total pain, Cicely Saunders expanded medicine's understanding of the multidimensional nature of suffering, the way in which forms of distress that are psychological, spiritual, and existential may interact with and compound physical forms of suffering. And in his writing with colleagues, Balfour Mount, who I will remind us is a retired urologic surgeon from McGill, expanded on the possibility of healing. Healing, he wrote, is a relational process involving movement towards an experience of integrity and wholeness, which may be facilitated by a caregiver's interventions, but is dependent on an innate potential within the patient. A relational process, meaning that it takes place within the context of relationships. Now, Dr. Mount took the importance of healing and of relationships one step further in saying that what we're trying to do in palliative care and all medical care is establish healing connections to be experienced by those who are ill or dying and their families. I'll leave that there. Okay, so having spent this time discussing why I think relationships and serious illness matter, let's move to moving on to talking about how we build them. So quality improvement in healthcare gives us a nice frame for thinking about building or refining healthcare services. In particular, Avidis Donabedian articulated a model of healthcare quality in the 1960s that's both very simple and very useful, and can provide a framework for thinking about prioritizing relationships in healthcare. In fact, he said something that explicitly ties quality improvement to healthcare to relationships, in saying that ultimately the secret of quality is love. If you have love, you can then work backward to monitor and improve the system. I would propose that the object of the love to which he refers is not a process, but people. So Donabedian proposed that we should try to link the outcomes of care that we wish to change with the structures and processes of care that make them possible. The structures of care are the physical and organizational characteristics where healthcare occurs. So you might think of this as the hospitals and clinics and how their services are arranged. The processes of care, what happens within those structures. These could include specific services like diagnostic evaluations or treatments, but can also include things like communication or documentation processes. So with this in mind, what might comprise the structures, processes, and outcomes of care that help us respond to and acknowledge the importance of relationships in serious illness? How might they look different from what we measure now? And what gaps can this model highlight for us in our understanding of what processes and structures are necessary? So I think it's important to mention that much of what follows in the next few slides is grounded in both evidence and imagination. Evidence, some of which is drawn from work that I have led or participated in as a faculty member at Ariadne Labs in Boston, informs my own vision of the structures, processes, and outcomes that inform care. But in the next few minutes, I challenge you to imagine what you see as the potential structures, processes, and outcomes of care that support relationships in serious illness. And to be clear, we're drawing from what we know to reimagine the healthcare system in ways that are both big and small. So as a palliative care physician, I would be remiss in pointing out that an established and ever-growing body of evidence suggests that palliative care is a critical part of the infrastructure of serious illness care. And in fact, if you have a serious illness and you do not have access to palliative care, then you do not have access to the best quality care. That palliative care has a specific appreciation for the importance of relationships means that part of the way we must structure care in our health systems includes a robust palliative care presence in various settings. And yet, we know that there are shortages now in the availability of palliative care clinicians to care for all those affected by serious illness. And this problem is going to get worse in our aging society. And I'll remind you that aging and serious illness are tightly linked to each other. So a recent paper in the Journal of Clinical Oncology suggests something about how we might structure palliative care services to more precisely meet the needs of people affected by serious illness. In this model of precision palliative care, or precision model of specialist palliative care, you could say, we could imagine routinely assessing people with serious illness for needs that may be met by members of the interdisciplinary team and scheduling services that intend specifically to address those needs. This population health approach, as it has been called, represents an important opportunity to more proactively respond to the often predictable needs of those affected by serious illness at different points in their illness trajectory. Implicit in all this is that we have the capacity to systematically identify patients who have serious illness. Now, we also know that generalist palliative care skills are those that can be taught. Among the most important for building relationships are communication skills. And it should be noted that poor communication is the greatest threat to relationships between anyone, including clinicians and patients. And while these quote unquote soft skills are among the hardest to master in clinical care, we fail to routinely teach them. For this reason, I would add to our wish list of care structures the systematic implementation of training programs that support clinician education in communication approaches that promote relationships. And finally, because patients value being known and because they are cared for by healthcare teams across time and space, we need information systems that promote the transfer of patient-centered information across multiple sites of care. In the hospital in which I work, which has all the outward appearance of the hospital of the future, we lack the information systems to easily find the kind of information that promotes high-quality relationships. I keep having a fantasy that a minister of health is going to come sit down by my side and say, can you look up for me something about this patient, and watch me spend an hour trying to do so. Not good for relationships, not good for care. So I'm just highlighting in the red circle all of the things that we have the capacity to do in our world and in our society, and that we don't do, don't have currently. So what processes might we want to ensure such that relationships are prioritized and promoted in healthcare? Some of the structures allude to these processes. For example, if we have systems to identify patients, we must have the processes in place to do so at the right time and at the right place. If we need structures in place to train clinicians to have better conversations in serious illness, then we would benefit from processes to prepare these patients for clinician reminders such that they have the right conversations with the right patients at the right time. And clinicians may benefit from tools like this one, the Serious Illness Conversation Guide, which helps clinicians sensitively share prognosis in ways that align with patient preferences and help them elicit information about goals, values, and preferences that will shape treatment decisions. And finally, we need to use information systems to ensure that such information is documented and accessible at multiple points of care. Building these structures and processes is work in which we're engaged right now here in Montreal, I'm pleased to say. Why is my it's got a mind of its own. Okay, so so there's a very important question to answer around what outcomes we could measure that prioritize and promote relationships in serious illness, and in fact, in healthcare broadly. There's a saying that if you can't measure it, you can't change it. There are ways in which we measure certain relational outcomes in research studies typically. We have, for example, measured trust and therapeutic alliance. We can measure the quality of communication. We can measure perceived empathy. And more recently, people involved in measuring the quality of serious illness care have started to measure the degree to which someone feels heard or understood, which is a measure that I really like. The consultation and relational empathy or care measure, and I'm not going to put it up on the screen because it's just long, but it was developed by a team in Scotland, and it asks questions about the degree to which a clinician, now pay attention here, I want you to listen, remember this list, okay? The degree to which a clinician makes you feel at ease, lets you tell your story, really listens, is interested in you as a whole person, fully understands your concerns, shows care and compassion, is positive, explains things clearly, helps you to take control, and makes a plan of action with you. Now, implementation of measures like this would represent an important advance in patient care, certainly in the setting of serious illness. But I have to ask you, how many of you feel that you've met clinicians that do all or even most of these things well? I see some shaking heads in the room. So I will say that the risk of measuring these things is that we shine a very critical light on the healthcare system as it's presently structured. So I want to end on something that I find very inspiring, which is a description of connection by an American clinician researcher named Anthony Suchman, who wrote about relationship-centered care around the last turn of the century. And he wrote that connection is often marked by a physiologic reaction, such as goose flesh or a chill. by an immediacy of awareness of the patient's situation as if experiencing it from inside the patient's world, by a sense of being part of a larger whole, and by a lingering feeling of joy, peacefulness, or awe. Now imagine if we had a healthcare system that attended to these sensations or even sought to promote them. There's much that we can learn from the care of people affected by serious illness. They face much uncertainty and are deeply vulnerable as they traverse our healthcare systems in search of a route towards well-being. And I think we have an opportunity in healthcare that goes beyond technologies and treatments to helping people feel truly cared for. Our attention to relationships is the most important step in making that possible. Thank you.
Sure, yeah.
So thank you, Justin, for that very inspiring talk. And we will have a period of questions now, but I did notice that Mr. Samuel Brauman joined us while Dr. Sanders was speaking. So I wanted to give Mr. Brauman a chance to send his greetings from the St. James Literary Society. So Mr. Brauman, if you're there, would you like to say a few words?
He's muted.
Mr. Brauman, you're on mute, so we have to unmute you.
Okay.
There we go.
Okay. So firstly, I'd like to say that to apologize for being late. There's no excuse for it. So please just accept my apology. I'm very delighted to learn about the different aspects of palliative care. And I think nobody knows better than me how close we are to those things. Okay, so finally, I'd just like to say that we at the St. James Literary Society are delighted to be part of these wonderful meetings once again. So thank you, everyone, and have a wonderful summer.
Thank you very much, Mr. Brauman. It's always delightful to see you at this annual event and in between sometimes. So I'm going to turn it now to a period of questions, and Marie in the back has been monitoring the chat. And I don't know if there are any questions in the chat, Marie, but are there any questions here from the audience? Oh, we have lots of questions from the audience. That's very exciting. How about the gentleman over here?
I wanted to say the high level of divorces, the breakup of the family, the high level of divorces, the breakup of the family. A lot of people are living alone.
Yeah.
More and more are living. What's going to happen with those people in the future? They're going to have a relationship with who? They're going to make in the future with AI getting better and better. We're going to have robot friends and robot nurses.
So perhaps I'll take
in case people didn't hear, the gentleman in the audience was asking about, in some ways, the future of relationships in a setting of social breakdown in many forms, and how we're going to replace that. And I think there has been a lot of attention to what kind of relationships we're going to have with artificially intelligent beings in the future. You know, I think that the issue of loneliness is critically important. There are societies like Japan, for instance, that are ahead of us on an aging curve and have tremendous problems with loneliness. It's also become the #1 focus of the United States Surgeon General. And there was an article in the New York Times just in the last couple of days talking about the importance of addressing loneliness in our society. I think, I would like to think that palliative care could, and our attention to relationships and serious illness could address some of those problems, what I would like to draw attention to is the importance of relationships, the catalytic nature of relationships between clinicians and patients themselves, because I think that these relationships matter in different ways for different people. So for people who don't have others in their lives, the relationships they develop with healthcare teams are of critical importance. And we have all worked in hospital scenarios where we become the family of the person who's there. And our ability to lean into that, I think, is really beautiful and really important. There are other ways in which people experience broken relationships in different aspects of their lives. And in the setting of serious illness, where they often don't know how to talk about the things that matter most to them, the fears that they have, the worries that they have related to their illness, the ability of a clinician to model that conversation in a sort of psychotherapeutic sense is really important, and actually allows them, can serve as a catalyst for the relationships and conversations they have in their own homes or in their own lives in other places. So I think these questions that you raise are very important. And I would like to believe that our attention to relationships in healthcare can be a part of the solution. Another question?
Thank you, Justin. It was very interesting, and I really like the way you focus on this important question. Me, I have a question for your questionnaire from Scotland.
Yes.
You know, how is it possible for a clinician to match all this perfectly, all the answer, of this questionnaire? And do you think a clinician has to do it, or is it more a team, a palliative care team? Because I'm not sure a patient will want to deal with all of these aspects with the same person.
So that's such a good question. So I think that there's a clue to the answer to this in some research that we did looking at empathy. Okay, so we asked patients with cancer, this is a few years ago, we asked patients with cancer at Dana-Farber Cancer Institute what behaviors they felt comprised empathy in their physician, or demonstrated empathy in their physicians and other clinicians that cared for them. And some of those were about communication. Almost very few of them were about what we often think empathy is, which is this sort of internal sense of being able to, well, you could say what might be the internal sense of being able to sort of put yourself in someone else's shoes. Very few people commented on that, but they said things about how when a doctor listened to them, they felt that that was an empathic behavior, or a behavior that demonstrated empathy. And, things that we might, so listening to them, asking about the other elements of their life that are important to them. But then there were things about the system itself and the way that it ran that helped them feel cared for in ways that they would say, oh, this is empathic. That they would rate their clinician as more empathic as a result of things for which the clinician had zero responsibility. How long they waited in the waiting room, for example. So I think that, what's problematic about these multi-item questions, that as intuitive as they are, like on face value, all of those things make sense. I mean, we would love that all of those things are met. I think there's probably a more general sense of how a patient feels cared for that would lead them to rate each of those things highly without thinking maybe even specifically about what each of them are. And that's why I like this measure of heard and understood, because while it violates sort of every rule of survey development and measuring two constructs in the same sentence, it actually was able to capture something across a population of people affected by serious illness, for which there was reasonable variability to suggest that this might be a quality measure that we could use to assess change in behavior and in quality of care for this group of people. So I think there may be more, it may capture, that is, this idea that someone feels heard and understood may actually capture a bunch of those things in a less precise way as it relates to the behavior, but in a more meaningful way as it relates to the sort of all of them together and how someone feels when they feel well cared for. I'll just add on this subject before you come up. it is not uncommon where I hear something in the hospital, typically related to the care of someone with serious illness, typically when something hasn't gone well. And a physician will say something to me like, but they got the best care. And you know what I find really interesting about that, especially thinking maybe about a world in which we rely on algorithms to communicate, is that what they mean in that setting is that the patient got the algorithms, that we got them the chemotherapy that they needed for their disease, that we got them an aspirin when they had a heart attack, but something didn't go right. And I think what's really interesting is for us to think about, like, how can a patient receive the best care if they don't feel well cared for? I think there's a disconnect there that I think we need to address in some way. And part of it is by attending, I think, to relationships.
So there's a question in the chat, Justin, that I wanted to read to you. It's from Nyla Kuhlman, who says, thank you for the thought-provoking presentation. I would love to pick up on that last point, experiencing from inside the patient's world. I'm working on a project about how to better communicate aspects of the Parkinson's disease experience. Excuse me, I have to move the cursor. That are lost in translation when expressed verbally. I'm curious on your thoughts of how having drastically different embodied experiences might affect patient-doctor relationships or cause barriers to empathy.
Wow. Well, so I have to say, if you have not seen this person's work who asked this question, it is absolutely beautiful. She has developed these, I think I'm talking about the right person, but has developed these sort of theatrical performances that in some way convey the experience of people with dementia and Parkinson's disease. And it's really beautiful work. It's also a really tough question. I mean, I think that actually what you're working on addresses, tries to do that in some way. And I think that some of the ways that you're trying to measure that with certain colleagues in the McGill community is potentially valuable in understanding the way that people can experience connection to someone's experience in ways that are not conveyed by words. And I think Parkinson's presents a really interesting paradigm for this because of the sort of masking effects and the inability to show, in some cases in severe Parkinson's, emotion. I think also that clinicians have opportunities to, if we really believe that relationships important, then it leads us to invest in different avenues of maybe spending more time with people, or the kind of thing that allows us to develop relationships when some of the things that make relationships easy on the surface are gone. So for instance, one of the things we're trying to do is understand through research, what are the relational elements that people value when, for example, they speak a different language than the provider with whom they're working? Or for example, when they represent an underserved or marginalized community for whom there are traditional barriers to accessing healthcare. Those are the kinds of, it's different in that it's not related to the disease itself, but it's similar in that there are superficial barriers to the formation of relationships that can be navigated, and we should understand what it looks like when we navigate those well.
There's another question in the chat from Kelvin Kung. He says, how would you improve a palliative care room design for situations where the patient is not at home, but remains in a hospital's palliative care room? I'm an architect and my father was in this scenario.
This is such a great question. I mean, I think that I don't think it's specific necessarily to palliative care. I do think that if people have been to a palliative care ward or a hospice house and can see the ways in which the built environment is changed to facilitate sort of a more home-like environment, then that's sort of an easy answer. There's lots of ways that hospital palliative care, hospital-based palliative care units have sought to either through the arrangement of furniture or the arrangement of the activities in the day, for example, like a tea cart coming around at 3 p.m. to deliver tea, or whiskey, I don't know, whiskey, you know, whatever people want, but that gives them a sense of being more at home. And I think that there's a lot to learn about this. And I'll just give an example of some work that was done by a colleague in Boston who worked with maternity units around the United States and elsewhere to try to understand the ways in which the architecture of a maternity unit leads to the buildup of pressure that leads to C-sections. Okay, and this is a really fascinating question about how the built environment shapes behavior amongst clinicians. I don't know the answer to your question, but I think it's a really important question to look into. And I think if an architect wanted to come spend time with me on a hospital ward to think about this, I would really welcome the opportunity.
Honestly, I think lazy boy chairs are the key.
The Jerry chair.
Yeah, because, you know, sorry.
I'm Pearl Feldman. I'm a family doctor. Used to have a womb to tomb practice and now focusing more on the womb. There's evidence that with kangaroo care, which was taking care of very vulnerable neonates in low resource communities, that having mothers with the baby strapped on their chests in lazy boy chairs actually was an improvement over having them in incubators. I know when you're delivering a patient, if there's a lazy boy chair in the room where people can take a nap and mothers can move around, it's a huge advantage. And so with palliative care, you need some place where people can just be.
Thank you for that. Is there another question? Yes.
I was just going to ask, obviously there's lots of pressure on family doctors and palliative care doctors and just generally in our system as we kind of have a shortage. So how to balance also like the feasibility of actually spending, you know, we mentioned like more time so you can look at the person as a whole, and whether you first kind of part of the question, whether you think that's feasible with the pressures, and also looking at like caring for the doctor, the physician's own personal relationships. So under that pressure and making sure they care for the patient at all times and spend the right amount of time, that they're also able to have, you know, care for their relationships with their family members. And how do you think that's possible to have that balance?
So I think this is a really important question. It makes me think about two things. One is that in training, I do a lot of training of clinicians in practice around communication skills in serious illness. And the first thing they say when you ask them what are the barriers to them doing this is they say it's time. Okay. But what they're imagining is that every person that walks through their door needs that 30 minutes to have a conversation. And that's just not true. Nor does it account for the fact that all of us as clinicians find that we're caring for someone who, in the context of a 15-minute visit, takes an hour and a half. And so I think the question in some way is about how we're more proactive in meeting the needs of the patients that we care for. And that's why I like about this precision palliative care model. It fits nicely too with a model of care where everybody's trying to be more precise about everything. And we're saying that there's care delivery models maybe that allow us to be more precise in how we spend time with people. There are people that I see in clinic who, you know, I value the opportunity to build a relationship with, and I also don't need that much time with them. And they get the same amount of time as someone who needs a lot more. And I think if we take a more proactive look at how we care for people, we could build processes of care that allow us to prioritize certain people at certain times for certain things. Now, in terms of how clinicians care for themselves, you know, there's an epidemic of burnout among clinicians, right? Physicians and others. I think part of the, you know, it's an interesting problem, and that the solution doesn't lie in removing the trigger, okay? The trigger is, for instance, electronic health records. We need them, but they're also really hard on clinicians, okay? And what we found is that the real solution to burnout is promoting meaning in work. right? Because we don't want to get rid of something that helps us do high quality healthcare, like an electronic health record, or to measure its impact. But we need to promote activities that promote meaning and work. And what's interesting is that when I teach clinicians communication skills, in the context of even a role play, they come out of it and they say things like, wow, this connects me to why I went into healthcare in the first place. They feel good about it in ways that make the time investment worthwhile to them, because it makes them feel better about their job, and it connects them to something, you know, these relationships that they went into medicine for in the first place.
I'm gonna, as the person running the meeting, I'm gonna add to your answer if I may. So I guess I just, there we go. I guess I just want to say that developing relationships with patients saves time ultimately. It's not like, I think we think about it being a time sink, but it's not actually. It provides better care. And I've been a family doctor for longer than Dr. Sanders. And when I see my patients that I've known for 25 years, like I can pretty much tell by looking at them how they're doing. And it's just makes things much easier. Okay, we have another question for you in the chat, but I have to move the cursor again.
You want me? Okay, you got it.
Okay, so here's an interesting question from somebody called VT. So I don't know who VT is exactly, but that's fine. What do you think is the main contribution of palliative care to the medical system and to the social fabric of society?
Wow.
What would be, oh, and that's just a small question, because then there's another part. What would be the most important next steps in palliative care research?
Wow, okay. Let's start with the first part of the first question, which is about palliative care's contribution to the medical system. So I was having this conversation with one of the senior leadership in the hospital the other day, actually, and I said to her, you know, I think it's important to understand that palliative care is not just some ancillary service that represents something that we, you know, some place that we send people when there's nothing else to do, but rather an integral part of making sure that we provide the very best care to people in our health system. And I think we do it in two ways. One, hospital systems take care of a disproportionate group of seriously ill people. The people for whom hospitals care are disproportionately seriously ill. Okay, the mortality rate of people who enter a hospital in the setting of a chronic or serious illness is very high. Within the 1-year mortality rate, you know, upwards of 40–60%. Okay, so it's a very sick group of people often who enter the hospital. And again, we exist in a world where we're constantly reacting to the needs of a group of people for whom we could reasonably predict their needs. Okay, we know that, for example, that everybody in our system, in our healthcare system, who has advanced cancer that has spread beyond its original site, has a high risk of mortality and also has predictable needs and related to the disease itself or the treatment of those diseases. And yet we wait and we wait and we wait to refer them to the one evidence-based service that is known to help them live their lives better, because we're afraid of talking about the word palliative care. Okay, this is not a fear that is primarily sits with patients. It's a fear that primarily sits with doctors. And the reason I know that is because I've worked in systems where doctors say things like, I really want you to see my palliative care colleagues because they're going to help you feel better. And this is a really difficult time that you're going through. Now, unfortunately, there are many places in the world where people say things instead like, I'm afraid there's nothing more that we can do for you, so I'd like you to see my palliative care colleagues. And this represents an incredible disservice to patients, because the evidence base suggests that people benefit from palliative care throughout the course of the serious illness. And in fact, there's some evidence to suggest that while palliative care in big study, there's a famous study that was reported in the New England Journal that showed that a significant number of patients who got palliative care lived longer. There are multiple of these studies now, and they show that the earlier you get palliative care, the more likely you are to live longer, compared to later, getting palliative care later. Okay, and this So I think that, you know, so there's that for the number of people for whom we have serious illness, but there's also something about how we think about care and how we practice medical care that can really help those other clinicians who are not palliative care clinicians who care for people affected by serious illness. So for example, the communication skills that we teach, that we practice and can teach in healthcare systems can really drastically improve patients' experience in our healthcare system in multiple places. And so, you know, I'm bullish on palliative care, as you would hope that I would be. And I think that palliative care should be not just another medical service, but something that is really fundamentally a part of how we improve healthcare in our society. Now, I think in terms of the second part of the first question, there's been a lot, you know, there's been a lot of discussion there, you know, every decade it comes around again that palliative care may have the capacity to help us talk more about dying, and there are a group of people who come up every so often and say, if only we were more comfortable talking about dying, if only we could connect to our agrarian roots and when we lived around animals that died, that somehow more people would get palliative care and everything would be better. I have to say that I think that there's 4 to 5 decades of evidence that suggests that this just isn't true. People, you know, yes, when we confront our mortality, does it prepare us in ways that make us less scared when we get a serious illness? Maybe. Maybe not. Do people want to talk about dying? No. Do I want to talk about dying? No. Dying is like a moment. What I'm really interested in and what I think the real value of palliative care is that it's all about living. Okay, it's about squeezing every last drop out of what we've got. And what we've got is unpredictable. So I think the fact that we can accompany people in that journey, not attached to, not focused on their dying, but focused on all those moments that lead up to it. That's the real value of palliative care. It's not about a good death. I mean, most people die in their sleep. There's a lot of people who are afraid of dying, but most people die in their sleep. And our ability to help people get to the end of their life in a way that they can feel a sense of integrity, feel a sense of wholeness, feel even just okay is incredibly valuable. It's a wonderful thing. So that's what I think palliative care can do in society maybe, is normalize the idea that the end of life is actually really important. And I say to people when I'm caring for them in the hospital and they're saying, when is this going to be over? And I say to them, this is a really important time in your loved one's life and in your life. So let's sit with it and try to do what we can with this time. And I find that makes it a little easier for people to be reminded of that. Now, I don't remember what the second question was. Research, most important. Well, I obviously think that the most important issue in research in palliative care is about relationships, because that's the research that I want to do, or that we're doing. And I think it's really important I think it's something that our research in palliative care can teach us that benefits the whole of medicine. Okay, because it's helpful to understand when we do research, it's helpful to look at extremes, okay, of experience, because it tells us something about the average experience in a way, but we can learn in a more concentrated fashion. Okay, so learning about communication from people for whom the communication needs are so intense, like around serious illness, and like in the setting of serious illness, can help us, learn things about how to communicate with people in times that are less intense. And I'll give you an example if I have time. When I was a primary care physician, I used to have this challenge of diagnosing and treating hypertension, which is high blood pressure, okay? So someone would come in and they feel totally normal and their blood pressure is 150/90 on multiple readings. And I say to them, you have hypertension, you have high blood pressure. And they would say, I don't do this anymore, but they would say, but I feel fine. I'd say, I know, but you have high blood pressure. And so it's really important that I give you this medicine and that you take it. And they kind of say, well, okay. And then they go out of my office and probably don't take their medicine. right? And we know that rates of, non-adherence to medications in chronic disease are very high. Okay, now imagine, so what I learned in palliative care was that it's really important to start by understanding what's most important to people, okay? So then I thought back and I thought, wow, would I have been better at treating hypertension if instead of just trying to sell them on the fact that this number represented a disease, which represented heart attacks and strokes, I said to them, tell me about what's most important to you as a person. And they say, well, I have these grandkids that I love and I can't wait to see them grow up and go to college and maybe get married. And maybe I'd have some great grandkids. And then I would say, you know what? The biggest threat to that vision is having a stroke or a heart attack. And unfortunately, one of the things we know that predicts a stroke or a heart attack is having high blood pressure. So maybe we should think about trying to treat your high blood pressure. That would have been such an easier sell, right? This is a very common conversation in primary care, right? So I just thought, wow, these are the kinds of lessons that we can learn in caring for people with serious illness that can affect all of medical care. So this is why I'm interested in relationships, because I think these relationships really matter. And so I think we need to understand them better, because if we understand them better in the context of this extreme scenario in which we have to form relationships, sometimes very quickly, that we can learn something about how relationships matter across the spectrum of healthcare, and we can improve healthcare generally.
Justin, can you handle one more question?
Sure.
Okay.
I'm having fun. This is like a.
So Thomas Mindy, who's a family doctor at Facility Park X, writes, I'm thinking about how ironic it is that palliative care has to be a leader in the field of communication. Do you have any thoughts about how to teach this difficult to teach skill, attitude, approach?
I have so many thoughts. Yes. One of which is to never ask a closed-ended question. Because if you asked a closed-ended question and the answer is yes or no, so all I have to say is yes. No, I think I love teaching communication skills. It's something that we have to practice a lot in palliative care, and it's something that we need to be teaching across. So I don't think it's necessarily ironic that we learn from palliative care. It's ironic, maybe it feels ironic, maybe because it comes at the end of life, and maybe it's in part because of that we've had to develop these communication skills. We didn't develop them, but we put them to use a lot. And we've articulated frameworks around communication that can be really helpful. I'll just give you an example since we have people, maybe people are interested in an example. If you tell someone, if an oncologist, let's say, says to a patient, there's the median survival for your cancer is 9 months. What does that mean for that person? It's really hard to know, right? It means that half the people lived longer than 9 months, half the people lived less than 9 months. But for that person, who knows? And very often people walk away and they think, maybe I have 9 months to live, but honestly, I have no idea what that means, versus someone sitting down and saying, I really hope this isn't the case, but I'm worried with where things are with your cancer. The time could be short, maybe even as short as, 6 or 9 months. That's a very different approach to communication. It meets exactly what patients want, which is hope and realism. They want both. And often what I hear from oncologists is they say, I tried that realism thing and it was brutal. I would tell patients, you're going to die. You have less than 3 months, blah, 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 blah. And they said, and it was too hard. The patients didn't like it and I felt terrible. And so now I just say, we have another treatment. We have another treatment. We have another treatment. Neither of those meets the patient's needs, right? What people need to hear is they need both hope and they need realism. And I'll remind us that goals are the basis of hope, right? If we have a goal, we have a hope, right? That it'll come true, that we'll be able to meet it. And so when we ask people about what's important to them and what their goals are, it's reinforcing the idea that there's hope for something, right? And that's just a couple concrete examples of the kind of things that, we can teach and that really value, the patients really value, people really value. So anyway, I'm looking forward to, I'll just preview and just say that Marianne and I have talked a lot about the potential for expanding communication skills training across the community. And this is something that we're working on. So more to come.
UDAM is putting a 4-year communication skills program into their undergraduate curriculum.
So Dr. Feldman was just saying that another university in Montreal is putting 4 years of undergraduate curriculum, undergraduate communication training into their curriculum. I would say, and this is my question now for you, Justin,
Yeah.
so now that you're having fun, how do we actually teach communication skills in a system that consistently shows students not to use communication skills? So at McGill, we also have an undergraduate program in the art and science of medicine. And I had a group of students. And in the very first month of medical school, they had a palliative care experience where they came to St. Mary's Hospital and met with a patient who had colon cancer and he was dying. And he spoke to the group of 6 students for about 45 minutes about his experience and his diagnosis and so on. And I was so impressed with these students. They had been in medical school for like 2 weeks, but they picked up on everything. They said, oh, did you notice like how his wife got all teary-eyed when he mentioned how he was diagnosed in the emergency room? And did you notice how he looked at her? And they noticed all these things. And they were in their like 2nd week of medical school. And 2 years later, when they were doing clinical rotations, that had all been trained out of them. They knew how to take a medical history and do a physical exam, but they didn't notice those things anymore. And it's not because we're not trying to teach it, but they're working in a system that doesn't value it because they don't see that all the time. So I understand Dr. Mindy's question about how to teach it. I understand your response about how to teach it, but how do we maintain what we're teaching in a system that doesn't value it? How are we going to change the system, Dr. Sanders?
It's easy. I mean, this is something that my mentor, Susan Block, and I talked a lot about. And she had decided, being a leading educator at Harvard Medical School for a bunch of years and a leading palliative care physician in the United States, that, you know, it wasn't worth training medical students because of this exact problem. You know, if you teach them to swim one way and they enter a new tank in which everybody's swimming the other direction, they just turn around. But I do think it speaks, and maybe people who are not in healthcare will, but who have experienced healthcare will be somewhat dismayed by this. But, you know, I used to joke that medical school is a process by which we take these wonderfully idealistic, humanistic people and turn them into robots over 4 years. And there's something wrong about how we, and what's interesting is that medical schools in the last 2 decades have said, you know what, we need to find different medical students because it's not working. The problem is not the medical students, right? The problem is I say, okay, we need to find more humanists. That's probably how I got into medical school because I was had a background in art history. They're like, he'll do, he'll be able to talk to somebody. But you know, I think there's something wrong with the system. So I think, you know, her solution was to train clinicians in practice, right? I think we have to train, you know, so first of all, training alone doesn't change behavior, right? We have to change the system in which people operate. Okay, so how do we achieve culture change in a system around serious illness care? This is something I'm really curious about and have worked on for about a decade. And, you know, it involves leadership, engagement of leaders. It involves education. It involves structures of care. It involves processes of care. It requires measuring things that matter to patients and to clinicians and to health systems, right? How are you going to improve the cost of care, for instance? Once you know, and so you have to work on multiple fronts in order to make this happen. And the sad truth is that training clinicians or students alone doesn't do it. So That I can say is that we have to do more than training people. And so part of what we have to do is train implementers and people who are interested in organizational change to really get out there and start and try to work on the other side of the equation, which is changing the environment in which we practice to make it so that it's clear, that the value equation is clear for why we need to do this in healthcare broadly. That's the best I got for that one.
I think that might be a note to end on, since you're talking about system change. And I think that is probably where we're going next under your leadership. So I want to thank everybody for attending this evening. It was very interesting and very enlightening. And now we have a little gift for you.
So nice.
So this is to help your waistline.
Wow.
And we actually know that dark chocolate is excellent also for one's mood. So thank you very much for all you're doing in research and clinical care and education in palliative medicine and communication skills. And we all learned a great deal from you this evening. So thank you, Dr. Sanders, very much.
Thank you very much.
Contributed questions from the chat, and those of you who are here with us en personne, please feel free to come have more food. We have food left over, and we will be around for a few more minutes.
Thanks. Thank you. Thanks so much. It was,
I had my phone was like an accident.